All right. So, I mean, as healthcare workers, as clinicians, you know, research is part of your work, part of your career, and it's an important thing to do. But it's important to ask yourself, why do you choose a particular project? Why do you engage in research? Of course, it makes your CV better. Of course, there's pressure to publish papers. Of course, it's prestige, and it makes you able to apply for better positions, better jobs. But these are not the fundamental reasons to engage in research, and particularly in and particularly in clinical research, it's really important to have the endpoints in mind. And the endpoints is really thinking about patients, improving outcomes, improving standards of care, improving the healthcare system, so that we see at the end of the line better health in our patients and in our populations. But of course, the path between research and a particular project and that outcome may be very long, like Dana said with her project. It can be quite a few steps. So you need to be very clear when you have a research project where on that path your project sits. And it can be very early on. It could be as early as fundamental research and lab-based work. It could be as far as evaluating services, looking at impact, looking at cost effectiveness. But you need to be clear in your mind what's part of the question your particular project answers. And it could be that you've identified a gap in knowledge. We don't know if this intervention is better than that intervention. It could be that you need to generate this knowledge because you know that it will impact on health and healthcare. But the link has to be clear. You never do a project just because it's an interesting question or just because you think it's going to be a good paper. You have to be clear that at some point downstream, there's going to be an impact on health and on healthcare, and that it will improve the health of your patients and the health of your population. And
excuse me, Michael, but that's opposed to basic sciences, where research sometimes is done just out of curiosity, and you don't know.
So basic research. I would argue that even in basic research, yes, I think you can be a little bit more explorative, but ultimately you don't engage in a project just because it's interesting. You have to identify a question that we don't know the answer to, and the answer is going to either lead you to the next question that will lead you to something. It has to be clear, right? But in clinic, I think in clinical research, the type of research that we're talking about here, that path is much shorter. And quite often I have people coming to me with an idea, and the question you have to ask yourself when you have an idea is, so what? If I answer that question, how is it going to change the way I manage my patients? How is it going to change clinical guidelines? How is it going to change outcomes? Because if you don't have a clear answer to that question, you probably need to rethink the question. And there's a very, very important principle in research in general, but in clinical research in particular, and that is that the research must answer a question to which we do not know the answer for sure, right? And that's called clinical equipoise. It's unethical, it's a waste of resources to answer question, to engage time and resources and engaging patients in a piece of research that either we already know the outcome or that is not going to benefit patients one way or another. So the benefits must be clear and explicit. It doesn't mean that your project directly improves the management of your patient, but there has to be a clear path. It has to be there. And the research question has to be answerable. There are a lot of, and this is where refining your, going from an idea to an actual research question is work in itself, because you have to go to a question that you can answer with the, you know, in an ethical manner, with the resources, the time, and the skills that you have. And all these things are, you know, things that you think about very, very early on. So how do you actually go from an idea to formulating a research question? And this is really critical, because if you ask the wrong question, or if you don't ask it well, your project will fail. If you don't have, if you didn't define what you're doing correctly, if you didn't think about the resources, if you didn't think that you don't have enough patients in your hospital to actually answer the question that you need to answer, it's not going to work. So there's quite a lot of thought that needs to go into just formulating the research question. And it needs to be very clear and very simple. You know, is one treatment better than another treatment for a specific condition? Can a test detect a condition better than another test? Is, you know, factor A, B, or C associated with a particular increase or decrease risk in a particular condition, in a particular outcome? You really need to be able to, formulate your question into these terms. And this is what we're going to talk about in the next half an hour to 40 minutes.
Can I ask you some question, please?
Yes.
You say that if you don't have enough patients, maybe you have to think again about the research.
Mm-hmm.
Okay.
Because sometimes, you know, if you, we'll talk about statistics in future lectures, but the smaller differences, or the more subtle the effect, the more patients you need, right? So especially, you know, we're a mid-sized hospital with 300 beds. For example, if you want to look at I don't know, trends in a particular reason for admission in a particular ward, if you only have, you know, between 3 and 5 patients a year that come with that particular, it's very hard to actually determine.
Then
so
you can do collaborations.
So there's a lot of things you can do. You can do collaborations with other hospitals. You can include more years. You can broaden your case definition. All these things have pros and cons that we can discuss. But you need to, the feasibility, that having a good research question is not enough. You also need to see whether in your particular context, you can answer that question. We'll come to that. So generally, you will start, you know, you will notice something in your everyday clinical work, or in your lab work, or whatever you're doing, and you need to transform. And this type of generic question is what's called a background question. It's quite vague, and you know, it may be, if you're an oncologist, it may be, oh, you know, what is actually the best chemotherapy regimen for a particular type of question? What is the best surgical approach for patients presenting with X, Y, or Z? And you know, or you're seeing patients and you're seeing, oh, you know, I'm treating these patients, but I'm noticing that in this, you know, in older patients, this approach doesn't seem to work very well. These are things that you will notice, and then transforming this to a real research question that you can answer is going from what's called a background question, a generic question, to a foreground question, which is a more specific question. And defining that specific question is really the first step in a successful research project. So here I took an example in a cardiology example, which, you know, starting with saying, oh, you know, I'm noticing that my elderly patients with heart failure don't do particularly well. How can I treat them better? That is not a research question. That is a very vague question. It's an area that you noticed. And you need to move from that to something more along the lines of defining what your population is, what your intervention is, what your comparison is, and it may go from what is the best treatment from heart failure to, in elderly patients, does adding warfarin to standard treatment reduce the risk of thromboembolism? A much more specific question, and we'll see how to do that. So you will see that even when you start being specific, there are elements that the more you go, the more precisely you define them. What exactly do you mean by elderly? What exactly do you mean by, warfarin is clear what it is, but how much and how often? What exactly is standard treatment in your research? Because it needs to be standardized. It needs to be consistent. What is the level of risk difference you want to detect? How do you define thromboembolism? Is it a clinical finding? Is it a radiological finding? All these things, every word in your question needs to have a clear answer. Right? Another example, and this is a more real example because it's a project that Dana and I have been working together with a student, and it starts by saying, has COVID-19 changed attendance patterns in the emergency department? A very important question. But again, not a research question as such. And then you can transform this to thinking about what exactly, who you're talking about, what is the exposure, what is the outcome. And here it's gone from has COVID changed attendance patterns in the department to, compared with pre-COVID times, has the volume and nature of injuries in children presenting to the department different than during COVID time. But again, we need to define exactly what exactly do we mean by pre-COVID time. What is an injury? What is classified as an injury, and how we do it?
Because COVID time is different.
Absolutely.
The first closure, the second, you have
absolutely.
holidays, you have
Exactly.
pre-vaccine, post-vaccine.
Exactly. We're going to define the volume and the nature. What does that mean? Who is included in our children? What is the COVID period, and how do you define that? So there's actually frameworks, really well-established frameworks that can help you doing this and formulating a question that you can answer. And one of the most classic ones, and the ones that we're going to use here, is called PICO. And the PICO framework is a very simple framework with 4 topics that can help you define the elements that you need to define. And each letter stands for something different. The first thing is the population of interest. Who are you actually, who are you researching? Who are the patients, or who are the population, or the problem that you are addressing? The second one is the I stands for intervention. An intervention is, in some studies, you will actually do something to the patient. In some studies, you will just record what the patients have. So the I can either be what you do, or what is the exposure that you are interested in. What is the risk factor that you're interested in? What is the treatment? What is the test? And like much mentioned earlier, you need almost always to have a comparison group. And this is something that many clinicians fail to grasp. If you don't have a control group, it's very hard to attribute a change to a particular factor, because you don't know, maybe the change that you see would have happened anyway. You just don't know. So you need to think about who you're going to compare your group to, or what is going to be your control. And the control can be another group of people, can be another time period, can be a different treatment. But you need something to compare it to.
Or the same group that didn't have the intervention.
Or the same group that didn't have the intervention. So you can have the same people at a different time period. But you need to define it, and you need to think about what is an appropriate control group. It's not enough to have a control group. The control group has to be right, because if it's not right, you can introduce bias in your study, and the results can be invalid. We'll talk about that in future lectures on epidemiology. But always think, who am I going to compare my population of interest to? And finally, what is the outcome? What are you looking at, and how do you define that?
So is the comparison, can it be also from evidence in the literature?
Could be. It could be,
But
but
I only see what's going on in my ED compared to what the literature says about what happens in other places.
yes, of course it can, but you always have the problem, and it's I think it's more pronounced with so you can have what's either historical control, or you can have what's called a population baseline. You know, what is the outcome of my surgical patients versus the, you know, what is the rate of post-op infection in Ziv versus the national average, for example.
Okay.
That's fine, but you have to understand, you always have to think, is my control group actually a good comparator? Because maybe my population is older, maybe it's poorer, maybe they're different, you know, a different makeup.
I'm asking because in my research, the first part is descriptive one. I want to know what's going on here, so I can compare them to what's in the literature. I can compare to facts that the Ministry of Health have about how many postpartum depression women are in Israel.
Yeah.
And
So
the question is, how is our population different from others? Because it's unique.
correct. So
And what happens within the subgroups of that population? So
Your question can be, are we underdiagnosing, which is one thing, or is there, and then you have a higher percentage of postpartum depression within the women you survey, and also that maybe our population is more susceptible. So I was going to figure out how you analyze
exactly. So for example, you know, in Tzfat you have a higher proportion of Haredi patients compared with the rest of the other parts of the country. Generally, the population is poorer, more socioeconomically deprived. So, you know, that will go some way to explain differences. So you have to, you know, you can take whatever control group you want, but you need to understand what your control group is and how different it is, because the differences may be explained by different things. It could be explained by the quality of care in Ziv Medical Center. It could be explained by characteristics of the underlying population, and that is something you need to understand. But when you're doing, for example, and it also depends what your objective is. If your objective is quality of care control, then comparing one hospital with another hospital is completely legitimate. But you need to adjust for these underlying factors. And then it becomes really problematic if you use controls from the literature from other countries. Because generally in other countries, the population is completely different, but also the healthcare system and how people approach healthcare, you know, particularly the US, where a lot of the literature comes from, is very different.
completely different.
So you really need to think very, very
That's why
carefully.
that's why I don't have any clue about what's going on here, because there the system is completely different, and all the papers come from there.
Yeah.
I think
So when we go to the lecture about critical appraisal and reading papers, we'll talk about this. What is important is to really understand what you're doing. Like if you're using literature controls from the US, that you don't at face value assume that it's an okay comparison. Sometimes there's nothing else. If that's all you have, that's all you have. But you have to understand what are the potential pitfalls, and you need to take this into account into your research, and you need to explain this in your paper and in your research, right? So what we're going to do now is we're going to talk about each of these four attributes to help you define these. So the first element of PICO is the population of interest. And it's very useful, I think, to think about defining your population of interest in three different ways: in time, in place, and in person. Meaning, which population is it? Is it, you know, in Tzfat? Is it the population of Israel? Is it the ultra-Orthodox population in Tzfat? Like being specific about that. The time period that you including and excluding patient, and the characteristics of the population. And if you think about these three elements when you describe your population, you generally get to a definition that is already quite specific. So, for example, you may be interested in heart failure patients, to go back to our heart failure example. Right? But heart failure patients is not really specific enough to embark on recruiting patients. So if you think about time, place, and person, you can start seeing how you're going to define them. Individuals diagnosed between 2015 and 2020, or people who initiated, or people who are on treatment for heart failure as of a particular date. Residents in the north of Israel. Individuals admitted to Ziv Medical Center. People of a certain age, you may want to have age restriction, sex restriction, ethnicity restriction at a particular disease stage. All these things, generally you can classify them in either time, place, or person, but they become your case definition. And if you're not specific about it, it becomes very hard to know who is in your research and who is out of your research. And this is important because you need to understand the limitations and the characteristics of your group to be able to then choose an adequate comparison group and to interpret the results. You know, if you're talking about heart failure, if you're looking at patients, you know, elderly patients with risk factors is very different than young people with congenital cardiac malformations, for example, who may both have heart failures for very different reasons, are likely to respond differently to treatment, have different outcomes, etc. If you don't define this, you will include both, and basically you will look at results that will be difficult to interpret. So heart failure patients, you know, if you're interested in heart failure patients and you think very carefully with these three criteria, you can easily come up with a definition that then becomes very clear who you're going to recruit, who you're going to target. So from heart failure patients, you can arrive to something like all patients who are age 60 and over with NIHA category 3 or more heart failure, attending cardiology or patient services at Ziv Medical Center as of a particular date. Then it's very easy to then take a list of patients and say, you're in, you're in, you're in, you're in. Because if you don't do that, it's difficult.
That's the inclusion criteria.
That is the inclusion criteria, but it's not just for the inclusion criteria. It also will impact on who you're going to compare them with and what outcomes you're expecting and how you're going to interpret the results. So we're talking about children, again, same thing, you know, what age, where, over what period, again, time, place, and person. So, you know, from children, you can arrive to something like individuals age 0 to 18. And this is a big, you know, the type of clinical presentation in this group,
Many subgroups.
many different subgroups. You may need to divide it depending on exactly what you, so you need to think about this, you know, is it appropriate for a particular, because, you know, if you're looking at a particular type of injury, for example, that is predominant in younger individuals and you include older individuals, you will dilute your results. You will include people who are not actually susceptible to a particular type of injuries, and this will influence your outcome. So you need to have a discussion about what is the right age band. You know, this is again a project. You know, do you want to include everyone who attends the hospital versus people who are resident here? Because you have a lot of tourists who come to the north of Israel, and if they injure themselves on, you know, Tiulim and other activities, is that relevant to your research? Is it relevant to your population? You need to think about that. And again, a time period, a particular place and a particular time. Once you've defined your population, and often again, you have just to be very, very clear, there is never a right and a wrong answer. There's trade-offs, there's pros and cons, you know. The more vague you are, the bigger the sample size you're going to have, the more statistical power, but the less specific you're going to have, the more work it's going to be, and it's going to cost more money. You know, that there's the more you restrict, the less generalizable your results are going to be, but the easier the question is going to be answered.
But does it make sense to sometimes have like a big picture and then
sometimes
to
it makes
zoom
sense.
in?
Sometimes it makes
Like
sense.
you are more vague and you have the big picture, but then you know where to go more specific because it's more resources, it's more time, it's more. So you don't want to investigate all of them specifically. You want to know where to put your money, your effort.
No
your-
more Zoom.
No,
The important thing is understanding what question you want to answer, and the way you define your population depends on what your question is. You know, sometimes you need a very, very high level, you know, what proportion of the Israeli population is vaccinated against COVID-19? That is an important question. It's vague, but it's a starting point. And then once you have the answer to this, you want to know, oh, actually, are there differences in different age groups? Are there differences in different ethnic groups? Are there differences in different parts of the country? And you can zoom in, because you know if you're doing clinical research, if you then want to do something about it, for example, knowing that 73% of people in Israel are vaccinated against COVID-19, it's very hard to do anything about it because you don't know who the 27% are.
right.
So it's not really enough of a specific answer to enable you to. But it depends if you.
Good
But,
answer if we have herd immunity or not.
yeah, exactly. It really depends what you want to know.
Okay.
It really depends what you want to know. The second part of PICO is the intervention. You know, what are your population exposed to, and what are they exposed to could be an active intervention. You know, like a particular drug, a particular surgical procedure, or it could be a passive exposure, something that you know you want to know if people who drink more alcohol are more likely to end up in the emergency department. You're not giving them a bottle of arak, but you're just recording the exposure. So the intervention, it can be active or can be passive, just something that you record. But again, it needs to be specific, and again, you can define it. So you know, if you're interested in a particular drug, you have to define exactly how much of the drug, how often you give it, because you know, being on, I don't know, if you're interested, for example, in the effect of steroid treatment on immunogenicity of a vaccine, just an example. If you're on 5 milligram every other day, it's very different than being on 40 milligram every day. So you don't want to lump everyone in the same group, because you will end up with wrong conclusions, and you will fail perhaps to detect certain things. So you need to be very, very, very specific again. So just a few more things on the comparison group and the third element, the C of the PICO. It's really important and good practice to have a comparison group, because as I've said before, if you're just looking at a group and you do something and you don't compare it, it's very hard to actually suggest a causal relationship between your exposure and your outcome. Let me give you a very concrete example. A lot of my examples are COVID-19, because I do a lot of COVID-19 work, but you know, about a year ago, there was a whole controversy, I would say, with hydroxychloroquine treatment for COVID patients, right? Hydroxychloroquine.
Okay.
Yeah. And there was particularly a French infectious disease doctor who said, "Oh, you know, all my patients come into, or they're admitted for COVID-19. I give them hydroxychloroquine, and they will get better. You know, 96% of my patients were discharged after 10 days." That actually doesn't tell you much, because how do you know that maybe these patients would have got better anyway? And it turns out that actually the patients he admitted were quite mild to begin with. And there's no way of knowing if you don't have a group that you don't give a particular intervention to,
In a big enough sample.
in a big enough sample, you don't actually know. So, and when you did these studies, when you had the much larger randomized control trials where patients were comparable, half got hydroxychloroquine, half didn't, and there was no effect. So having that that comparator,
It
whether
happens
it's
all the time with bronchiolitis in infants, because people swear that works.
exactly,
But whenever they do a big sample, double blind, right?
yeah.
Nothing works for bronchiolitis, only time. Like
And this is
nothing
really
else.
important
But
because
people
as a,
swear that if they give hypertonic saline, it helps. That helps.
exactly, and you know,
But
in emergency management of patients, for example, you know, as an individual doctor, you may get a gut feeling. You're saying, oh, you know, if I give, yeah, like you say, you know, if I give, you know, a stat bag of saline to all my patients, I think, and it's important. Actually, you shouldn't ignore this. You shouldn't.
No, this is the starting point of
It's
that.
the starting point.
But I think as a physician, you choose your patient when you know it's going to work. So that you have a bias in collecting your sample when you go with gut feeling. When you do research, then you take the question in a more
Exactly.
sterile
Absolutely.
form.
Absolutely.
And then
And this is
really
also
it's
why,
the
you know,
question.
this is why also it's good practice to never do research by yourself, to have a team, to have colleagues that you discuss it with, because we're all subject to biases. And when it comes to case definitions, you know, maybe, you know, as you say, and we'll talk about bias later, but maybe you're convinced that giving a bag of saline to everyone who comes to the emergency department improves your study, and you want to prove this, and maybe you're not going to have a control group, and maybe you're going to include only patients who, you know, it's not like you want to falsify your results, but
natural
implicitly
bias.
one thing you want to show it's a natural bias, it's an implicit bias, and you will choose patients who are more likely to benefit to begin with. So having a comparator, and the important thing with the comparing group is that the comparison should be as similar as possible to the group of interest, except for the exposure or the outcome, depending on which one you're interested. So, you know, if you want to look at the effectiveness of a treatment in I don't know, young people, you don't choose old people as a comparator, because there are many other things that could explain differences. You want them to be as similar as possible. And this is also a challenge because you don't always have enough patients. And you know, the reality of clinical research here, we're not talking about randomized controlled trials when you can pick exactly, you know, if you're a surgeon and you have 50 patients coming with a particular presentation, these are your 50 patients. You can't change them. You can't make them younger. You can't make them older. You can't. So the important thing here becomes not only trying to make the groups as similar as possible, but also understanding what the differences are,
Right.
describing what the differences
And
are,
discussing them.
trying to adjust for them either at the design phase or at the analysis phase. And if you can't, discuss what the differences might mean and be very transparent about it and open about it.
And to find something in common with this group that you say.
Yeah, so you know, for example, if
Not just the difference and the same.
yeah, basically describing the characteristics and saying, you know, they are the comparative group was older than the intervention group, for example. So you describe the age, and then you explain: does this matter in this particular instance? Does this not matter in this particular instance? But you need to show when you're doing research that first of all, you did everything you could to make them as similar as possible. And when you can't, because the reality in clinical research is, you know, we have the patients that we have the samples that we have, but you go as far as possible to demonstrate that you understood what the differences are and what this means for your findings. Yeah. And by the way, the comparator doesn't have, it could be a different group of patients at the same time. It could be the same patients in a different group of time, at different time points. You can do, you know, before and after, for example. Not necessarily the same patients, but the same, you know, for example, I don't know, if you implement a new protocol, you know, like, for example, you implement postpartum depression detection protocol for all patients that come to the emergency department, and you're looking at the numbers of patients diagnosed with postpartum depression in your emergency department. this protocol goes in the entire department. So your comparator is probably going to be another time period earlier on. And there are issues with that. There are biases with that. But what you need then to show is that nothing else, the big change is this new protocol. And if you see, like a stepwise change at this point in time, then you can say, yeah, maybe there are other causes, but this is the most likely explanation. So in some instances, historical controls are appropriate. In some instances, it may be the literature because there's nothing else that you have. You're not able to have a control group. Sometimes it can be another hospital. You can ask, we have this, for example, we had a piece of work here about a particular COVID-19 management for patients in intensive care. And all the patients have the same protocol, so you don't have a comparison. So then what you have to do is find a hospital which is similar, and this is very difficult, which is similar in every aspect, in size, in kind of skills mix, etc., except for the management protocol, and then you can look at the outcome. Very, very tricky because so many things differ between hospitals, but also a possibility. Yes.
What do we say about those medications that people reported that I got the drug in COVID-19 in severe patients? I got the drug and a day later I improved. Does it make any sense?
So causality, that's a very interesting point. We will come to this in future lectures. We'll have lectures on epidemiology and causation. The answer is, in studies, generally, it's very hard to prove causality for sure, right? You will show an association. You will show that a particular treatment is associated with a better outcome. Now, to decide whether, there are better ways and worse ways to do that, but ultimately you can never prove 100% for sure that X causes Y. But you can make it the most likely explanation. And one way to do this is once you have your association, you're statistically, for example, you will say patient on remdesivir had a 30% increased likelihood of survival compared with those who were not on the treatment, and statistically significant, blah, 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 blah. One way that you're going to show or convince people that it's really the drug that's working is a certain number of criteria. One of them is biological plausibility. Is there a plausible biological pathway that this particular drug actually acts physiologically to prevent this outcome? Temporality, how long ago? This is a big thing, for example, in vaccine safety. People come and say, oh, my child got the MMR vaccine and 6 hours later he was, diagnosed with autism. Well, it doesn't really make sense,
This was proved to be anecdotal.
Yes, exactly. So, there's all these things that you need to think about. And this is the kind of things that you discuss. Once you have your results, you include this in your paper. You explain why you think that your exposure causes your outcome, or why you think that your findings are real and are relevant. Yeah? Okay, so this is the comparison group. And exactly like your population, it should be described as precisely as possible, and it should be as similar as possible to your population, except for the either the exposure or the outcome. So, for example, we'll go back to our two example of heart failure and injuries in the emergency department. You might decide that if you want to look at whether warfarin decreases the risk of thromboembolism in patients with New York Heart Association type 3, stage 3 heart failure, your comparison may be standard treatment. And standard treatment, you need to define what that means. It may mean following a particular guideline or following a particular protocol, but the patients need to be at the same time period. They need to be at the same disease stage. They need to be the same age. You wouldn't compare stage 4, like to take an oncology, let's take cervical cancer, for example, and you want to compare a particular treatment. You wouldn't compare, a person with advanced metastatic disease to a patient with CIN1. it wouldn't be a fair comparison. You wouldn't compare elderly patients to teenagers. So it needs to be as comparable as possible.
Regarding toxicity,
Yeah.
I can do it. It's
Okay.
my basic assumption regarding only toxicity.
Yeah. So
Just making it more interesting.
So this is if your question is, so it depends what your question is. If your question is this treatment valid in my patients, then your patients need to be comparable. If your question is, is age associated with worse side effects, then you want to compare the age groups. That's because that is your question.
Okay.
But you need to have a control group that is that allows you to answer your question. And finally, the O in PICO is the outcome, and the outcome is basically what you want to measure. And a good primary outcome should be easily quantifiable, which means you can measure it. You can hopefully sometimes objectively, sometimes subjectively. There are pros and cons to that. For example, with it's like toxicity, side effects may be very objective. You could say it could be self-reported well-being, for example. It's very different from measuring thrombocytopenia. One is a number, one is how the patient feels, and how the patient feels is subjective. And that's why you need good tools to measure these things. I think, in mental health, it's very important that you have validated standard tools that you can compare to other articles in the literature. But it should be specific, it should be reproducible. This is where validated method, if you're using, if it's well-being, that tools that are, agreed and universally used, if it's laboratory tests that are calibrated in a way that is similar to other labs, so you can compare this, and more importantly, that it's appropriate to your research question, that is going to answer what you need to answer. So that means, as I said, recognize standard tests, recognize standardized assessment tools, clear thresholds, and then you have to make choices, clinical versus diagnostic. For example, if you're interested in, shortness of breath, are you going to ask patients if they feel short of breath, or are you going to measure their respiratory rate, or are you going to measure their lung capacity or their diffusion capacity? Because all these things are different, and you need to decide what is relevant to your particular, outcome. Like, for example, I'm thinking, side effects of chemotherapy, nausea. Like for some patients, it will be, debilitating, and their life will be miserable because of it. For some, they're completely able to cope with it, and it's not a big deal. So you have to think: is it a good outcome? Because what you want patients to tolerate the treatment. So which one is important? You have to ask yourself these questions.
In emergency medicine, we talk about a lot about clinically important, because
Exactly.
you might have radiological findings of intracranial hemorrhage,
That
but you don't do anything with it.
Absolutely.
Do you risk a child with CT for something you're not going to do anything about,
Exactly.
and you don't care about it?
Absolutely.
So they started in the last years,
Yeah.
in papers of emergency medicine, talking about clinically important. I don't care if this child has a skull fracture,
Yeah.
if it's like a straight skull fracture. I'm not interested
Yeah.
in knowing that,
Yeah.
so I don't care about it. I
Well,
only care about
yeah.
those things that if I don't find them
Yeah.
are detrimental, and if I find them, I have something to do with it.
Exactly. Absolutely.
And then you do the statistics.
So
Does it
this
work
is.
doing
I mean,
CT or not?
there's a lot of questions like this. I mean, I'm not an expert, but a good example would be, screening, doing a PSA for prostate. It's a classic example
Right.
for PSA for
Right.
prostate cancer. And what happens if you find, is it worth doing? Because you will find a lot of patients with elevated values, and actually it doesn't. What is the clinical significance? Maybe.
Right.
So you need to think what is your outcome, and why are you doing the research in the first place? And again, is it going to make a difference to
Sometimes knowing too much also hurts the patient.
Absolutely.
Always.
Yeah. Absolutely.
And I have sometimes people saying, oh, you didn't do a CT, I did a CT in the morning and they have this and this. And I said, but
Yeah.
what, okay, so I know it.
What's the yield?
What's the deal? The child was hospitalized, he got a CT, he will fall again because children tend to fall more than one time in their life. And every time he falls, you're gonna do a CT and find some finding that doesn't mean anything. So it's also important when you plan the research, but also when you read the literature and you implement it on your daily work.
Absolutely. And
It's always risk benefit.
it is. And you always need to ask yourself at the very beginning, what am I going to do with the results?
Right.
Because if the answer is nothing, it's not going to change the way I manage my patients. It's not going to change the way we test patients. It's not going to be more effective. It's not going to. Then why are you doing the research in the first place? So you need to think about these things, and you need to define them carefully in a way that is clinically relevant. And you need to have these classifications and these decisions. Thromboemboli, are you going to look for clinical outcome or radiological outcome? Maybe you have microemboli that are of absolutely no clinical significance. Then maybe that's not the right way to measure it. With injuries, what actually constitutes an injury? Is there a classification system that exists that I can use that is well established? Because if there is, then you should use that rather than trying to come with your own. So with all the 4 parts of PICO, be as specific as possible and always link it back to what you want to achieve with your research, what you want to find and why you want to find it. So, here's an example of, our initial background question was, what is the best treatment for my heart failure patients? And we went through the PICO framework, and we changed this to in patients age 60 and over with stage 3 heart failure who attend cardiology outpatient services at Ziv Medical Center as of October 15, 2021. And are managed according to American Heart Association heart failure treatment guidelines. Does adding 5 milligrams OD of warfarin reduce the risk of radiologically confirmed emboli 6 months post-treatment initiation? A very answerable question, a very specific question. The extent, as Dana was saying, the extent to how specific you go depends on exactly what you want. If you want to change the guidelines here, you need to go to that level of specificity. If you want to know whether at the country level there is herd immunity, then you would stay much more generic. Or if you want to know toxicity of it will change your criteria. But you need to end up with something that you can answer, because the first question you cannot answer.
And then you can also what dose risks the patient with, and then you do.
That's
like
a different question. So you could have 3 groups, one with 5 milligrams, one with 10, one with 20. When you do vaccine trials, that's what you do, because you want to know which dose is effective, what is the reactogenicity, and there's a trade-off. So you need to test. It really all depends what your question is. That's why having a specific question determines how you design your study, how many patients you need, what is your case definition, etc., etc. Again, the example of COVID-19 and attendance. Has COVID-19 changed attendance patterns in the ED? A very vague question, and we transformed it to compared with the average of the 5 years before 2020. What is the annual frequency of injuries by age group, ethnicity, and type of injury among children aged 0 to 18, residents in the north of Israel, and attended the pediatric emergency department in 2020 and 2021. More specific, you have the time, you have the place, you have the person, you know exactly who you're going to look at, you know exactly how you're going to classify them. This is something you can embark on. But it's not enough, because you may have a very good question. The next question you want to ask is, can I actually do this? It's an interesting question. It's a clinically relevant question. Can I actually do it? And there's another frameworks. I love frameworks. I like putting things into boxes because it makes things easier. And one of these frameworks is called the finer framework. And you can ask yourself the following questions with your project. Is it feasible in my context? Do I have enough resources? Do I have enough time myself? Do I have enough staff to do it? Do I have enough money to do it? Is the study design realistic?
No.
No, but there's no point, there's no point starting something because you don't want
But
to
that's
say,
what's difficult. in
It is
Ziv Medical
difficult.
Center because.
so if the answer is no, then there's different things you can do. You can change, you can make the research more modest, you can try and get more resources, or you can say, well, this is not worth doing in the first place, or we can't do it, we're not the right. And there are a lot of questions like this. There's a lot of really interesting questions, but Ziv Medical Center is not the right place to answer them because we don't have the right patients, because we don't have enough resources. But for some things, it's an amazing setting to answer. So you need to think about your context because there's a certain reality in terms of money, in terms of who your patients are. Ziv Medical Center is not the right hospital to look at, outcomes in African Americans because we don't have African American patients. I mean, it's a stupid example, but you can think about the same concept that is, it's not a good place to, if you want to look at particular outcomes in a particular type of surgery, and there's only, 5 surgeries per year with their particular procedure or particular approach, maybe it's not the right hospital, or maybe you need to team up with other hospitals. So you need to think if it's feasible. Obviously, the interest we talked about, the novel is important as well. And any good research project should start with a good literature search. Has my question been answered already? And if it has, is it applicable to my context? Like you said, some research, if someone's done exactly the same thing or something related, but in a completely different context, you have to think, can I use these results in my context? And if the answer is no, then it's completely legitimate to do it again. But when you have huge body of evidence, you're not going to start a trial on, is hand washing efficient in reducing infection in the operating theater today? Because we know the answer. There's been, millions of papers, meta-analyses, there's the body of evidence. You may think, is this scrubbing technique better than that scrubbing technique? Maybe that's a relevant question, but you need to look in the literature to understand where the gaps are. And this is really important because otherwise it's unethical, it's a waste of money, it's a waste of your time, it's a waste of anybody's time. And the ethics is also very, very important. Of course, you should only engage in ethical research, and ethical doesn't only mean that you don't torture your patients, but actually denying patients of a treatment that is shown to be effective is unethical. Sharing details of medical history with other people is unethical. And generally in hospitals, there's a safeguard for that, which is the ethics board. So you need ethical guidelines and approval for your particular work. And finally, the last thing that we talked about is it relevant? Does it actually matter? Is it actually going to make a difference? Because if the answer is no, then you should stop.
And I want to ask a question about the visibility. For example, we have an intervention that we do in our department. We do a enlargement for the obstetric tube, getting balloon into the obstetric tube, and we enlarge it. This procedure, it's done already in Israel. So I think if I can have to prospective research, I can have maybe 10 or 20 cases in the next some years. So in Israel, it's not done so much, and even in other places. But in Germany, for example, they done high volumes.
Mm-hmm.
So is it a good idea to do this research or not? Because in Israel there is no, they did this, לא עושים את הניתוח הזה הרבה. בחו"ל עושים את זה כל כך הרבה. אז הם שווה לעשות ניתוח כזה, שווה לעשות מחקר כזה או לא?
It depends what your question is. you know, it
יש לך
depends.
חוזק סטטיסטי.
It depends if you if
I guess I don't have because I first
לא,
I know
שאלה
that
מה השאלה, יש דברים שמספיק.
I want to compare two groups, like to take a prospective study to take the group of intervention. I will give them a questionnaire of pathological symptoms, like and quality of life, and to compare to another group that the intervention is nasal spray. Or
So
something
if
like
you have a small sample, you will have difficulty getting the two groups to be
No,
similar.
I know.
Because in this group you have more women, in this one you have more old people, and
Contact
And
your colleagues
and
in
you don't
Germany.
really-
and-
You don't assign randomly, though. And you probably take the worst cases and you offer them this procedure.
but
Separate.
if there's other countries that take this approach and you know, it's shown to be effective, it's shown to improve increase quality of life compared with the standard approach that you take here, then you have to think sometimes it's important, sometimes the context really matters, sometimes it doesn't, you know, like particular treatments that are dependent on the cultural context or maybe the genetic makeup of the population, then it makes sense. For certain things, you know, like, I don't know, surgical approaches to tibial fractures, it's unlikely that it's going to be very different. So you have to think, is the evidence that exists from other countries or other hospitals good enough? Do I feel confident that I can use this evidence and apply it to my population? Or is there a reason to believe that my population is different for reason X, Y, and Z, and therefore I'm not sure that this evidence is relevant, is relevant to me? Yeah?
Okay.
So hopefully if you go through that process through PICO and finer, you will end up with a research question that is specific and realistic for your context. And then from there, generally you have one or more objectives. And the objective is basically rephrasing the question to things that you're going to do. And sometimes, often, once you're there, in your brain, there's a lot you think, oh, this would be interesting, that would be interesting, I can answer this question, I can answer that question. And it's really important to stay focused because your project can often answer many questions. You know, once you start collecting patient data on patients, you're thinking, oh, you know, maybe this is also interesting. Maybe I should also look at the impact of this and that. But you need to stay focused and you need to decide what the main question that you want to answer is and stick to it, because the question that you want to answer will determine exactly the design, exactly the size of the sample, but also how you write your paper. And also where you're going to get money for it, which journal you're going to submit to. So if you're too scattered, then it's very hard to achieve any of these things. And really, you shouldn't have more than one or two main objectives, and you can have a few secondary objectives, but really not too many. If your paper starts saying, or your protocol starts saying, I'm going to answer questions 1, 2, 3, 4, 5, and 25, you have a problem, right? It means you're not focused enough, and you need to refocus. And it could be that you have a very rich data set that you collected data, and you think, oh, this would be interesting, that would be interesting. Don't put it all in one project. Just design a project that answers the specific question. And then if you have another interesting question and useful question that can be answered, then it's another project, and that's fine. And then you can have, you know, then you're getting into more of a strategic thinking, like you were saying earlier, Dana, with a research plan to say, in the first phase, I'm going to answer this question. Then once I have the answer, I will use the results to answer this question and this question. And in the end, this is what I will have. I will have a service, you know, I will have a unit in my ED to give whatever treatment needs to be given to patients yeah, but you're not going to include this in your first paper or in your first, you need to divide it and have a plan. So in order to do this, so we going back to the injuries in the emergency department example, here we have a few objectives. The objective could be comparing the frequency of specific groups of injuries presenting before and after COVID-19. It could be to compare different ethnic groups or age groups. It could be, and it depends what your primary objective is. If your primary objective is service planning, and you want to know, am I seeing more? Am I seeing less? Do I need to hire 2 more nurses? Do I need a new skill set? Then maybe you focus more on the volume before and after. If your objective is more health inequalities, are certain groups suffering more than another? Then what you're really interested in is the comparison between different ethnic groups. You can answer these questions with the same data set, but you just need to focus on the one that you're interested in and not try to answer everything. Right, so to conclude, the very first step is in defining your question will determine the success or failure of your project. Don't embark on pointless research. Don't do things that actually really have no clinical impact, are unrealistic, where the evidence already exists. Try and be as specific as you can in time, in place, in person. Don't underestimate the time and resources each task takes. A good rule of thumb, from my experience, is whatever time it takes, you think it takes, multiply it by 2.
Just 2?
As a minimum. So if you think, I'm going to work on this 2 hours a week, think 4 hours a week. If you think, I'm going to ask a student for half a day, hire him for a whole day, because there's always complications, always. Define, set yourself for success, don't set yourself for failure. Define a question that you can answer. And it's okay to refine the question as you go along. The example I gave you from, what is the best treatment to heart failure to the complex specific, it doesn't happen in one day. It happens through discussion with colleagues. It took us, months to come to or weeks. It gets refined through reading papers, speaking with colleagues, thinking when, sometimes, when you're in the shower, you're like, oh, actually, you know what, this is wrong. I want to do this instead. And then you go back and it's okay because it's a process. And once you finalize your question, and once you know, stay focused, it's very easy to be distracted thinking, maybe this is more interesting. Maybe this is a better, no. Finalize your question and stick to it, even if your findings are not what you expect. And sometimes you think you're going to find something, and this is really important. You don't embark on a question that you already know the answer to. If you know the answer, then there's no point in doing the research. But sometimes all of us have hypotheses. You're a surgeon, you're an oncologist, you're a urologist. You have expert knowledge, and you expect certain things. And sometimes you find what you expect. Sometimes you don't. And if you don't, you have to think yourself why. It doesn't mean that your research is wrong. Maybe your assumptions were wrong. And sometimes you have negative findings, and that's also very important. Not finding something, finding that a treatment actually doesn't help, or finding that the super cool, innovative robotic approach is actually not better than open surgery. That's a finding. That's important. And don't do it yourself. Speak with colleagues. Speak with us. Speak with friends in other hospitals. Because you will get better, you will get different ideas, you will get different point of views, you will get remarks that you haven't thought about, and give yourself the time to come to the right question. You will get the slides, and I strongly advise that you look at these. There's a couple of short YouTube videos, a couple of papers. I think they're useful. They reinforce the points that we went through. If you have time, they're not super complicated. When you have 10 minutes, 15 minutes, go and have a look. And what we're going to do now, we have 30 minutes. We can do this with coffee, with biscuits, with food.
There's we can make sandwiches. There's some stuff in the kitchen. We should go there, get our sandwiches, and come here and support.
So I'm going to stop the recording now.